In the section on the uterus, I will cover premenstrual syndrome, menopause, abnormal uterine bleeding, and dysfunctional uterine bleeding, and complete the section with contraception. Premenstrual syndrome and premenstrual dysphoric disorder begin when women are in their 20s and 30s. There's an important distinction here. Premenstrual symptoms occur in 75 to 80% of women. PMS and PMDD can only be diagnosed if these symptoms severely disrupt daily life. Premenstrual syndrome is a group of physical, mood-related, and behavioral changes that occur in regular, cyclic relationship to the luteal phase of the menstrual cycle. Again, it's important to note that they interfere with some aspect of the patient's life. This affects about 5 to 10% of women. Premenstrual dysphoric disorder is a more severe version of PMS. It is listed in the Diagnostic and Statistical Manual of Mental Disorders as a specific set of at least 5 of 11 possible symptoms, with at least one core symptom being depressed mood, anxiety or tension, irritability, or anhedonia. PMDD affects about 3 to 5% of women. PMS is a heterogeneous disorder with over 200 symptoms attributed to it. Common symptoms include headache, breast tenderness, pelvic pain or bloating, and irritability or lack of energy. The etiology of PMS is not well understood. There are many theories which have been proposed, which include altered estrogen and progesterone levels, endorphins, catecholamines, vitamins and minerals, but none of these provides a unifying theory. It is interesting to note that many disorders are known to worsen during the luteal phase of the menstrual cycle, diseases such as IBS or major depressive disorder. There are no diagnostic tests for PMS or PMDD. The patient needs to chart her symptoms, and the physician needs to rule out other causes such as thyroid disease or anemia. The diagnostic criteria involve presence over at least 2 consecutive cycles, being symptom-free in the first part of the cycle or during the follicular phase, along with relief of symptoms within 4 days of onset of menses, and symptoms being primarily present in the second half of the cycle during the luteal phase. Key to remember that there has to be dysfunction in social or economic performance. There are several different treatment modalities for PMS or PMDD. Lifestyle interventions have proven to be effective and include limiting caffeine, alcohol, cigarettes, and chocolate, the addition of aerobic exercise, and increasing calcium and magnesium in the diet. Pharmacologic interventions include NSAIDs for dysmenorrhea, and for severe disease, SSRIs, with sertraline or fluoxetine being the initial choices. For recalcitrant disease, you can consider hormonal suppression with GnRH agonists, which are shown to be effective for short-term relief, although are not the best long-term option. So let's turn to menopause. Recall, as opposed to male gametes, which are renewed on a daily basis, female gametes are fixed in number and diminish throughout life. Menopause is the permanent cessation of menses, and the symptoms are due to permanent cessation of estrogen production. The median age of onset of menopause is 51 years of age. There are some important physiologic changes that occur during menopause. Some of the early changes involve the oocytes producing less estrogen and progesterone. As the remaining follicles become more progressively resistant to FSH, levels begin to rise. Menopausal levels of FSH are typically greater than 30 milli-international units per milliliter. LH levels also begin to rise, and the theca cells continue to produce testosterone and androstenedione. The menstrual cycle shortens, due primarily to the follicular phase shortening, where the luteal phase remains the same. Some of the late changes involve changes in sex hormones. As mentioned, testosterone and androstenedione become the major products from the postmenopausal ovary, albeit at lower levels in the premenopausal state. Estrone, rather than estradiol, is the primary estrogen in the postmenopausal woman, made primarily by peripheral aromatase. There are some key symptoms of menopause, which should be recognized on the Step 2 exam. and they include menstrual irregularity, sweats and hot flushes, mood changes, and dyspareunia. The hot flushes are the hallmark signs of menopause and occur in about 75% of women. It's important to recognize dyspareunia, as this is typically due to lack of estrogen and urogenital atrophy. Women are typically symptomatic for an average of 12 months, but some experience symptoms for years. Physical examination is significant for a decrease in breast size, vaginal or cervical atrophy, and uterovaginal prolapse. It's important to recognize atrophic vaginitis, which presents as itching, burning, or dyspareunia. And again, this is due to the vaginal epithelium being estrogen dependent and the lack of estrogen in the postmenopausal woman. Bone demineralization naturally occurs with aging and is exacerbated in women after menopause. This is due in large part, again, to decrease in estrogen production. Recall the physiologic connection. There are estrogen receptors on osteoblasts, and lack of estrogen affects the development of cortical and trabecular bone. Bone density decreases at a rate of 1 to 2% per year in postmenopausal women versus only 0.5% a year in perimenopausal women. Treatment of osteoporosis can include calcium supplementation, selective estrogen receptor modulators or SERMs such as raloxifene, or bisphosphonates. Hormone replacement therapy is indicated for short-term symptomatic relief as well as the prevention of osteoporosis. HRT includes estrogen with or without progesterone. Contraindications in this case are important and include estrogen-dependent carcinoma, such as breast or endometrial cancer, or a history of pulmonary embolism or deep venous thrombosis. Other contraindications include undiagnosed abnormal uterine bleeding, stroke, myocardial infarction, or liver disease. Key step 2 point. Hormone replacement therapy is associated with endometrial hyperplasia and can lead to endometrial carcinoma. The clinical pearl here is that if a woman still has a uterus in place, in other words, has not undergone a hysterectomy, you need to give estrogen and progesterone, not just estrogen alone. I'm going to talk about one of the most common reasons that a patient presents to the gynecologist, and that is abnormal uterine bleeding. We're going to talk about the different types of abnormal uterine bleeding and the etiologies associated with those types, starting with menorrhagia, which is heavy, prolonged menstrual bleeding, and you can also see gushes of blood and clots. A specific definition is greater than 80 milliliters of blood loss in a cycle, or bleeding for greater than 7 days. Common etiologies include endometrial hyperplasia, uterine fibroids, dysfunctional uterine bleeding, and the presence of some types of intrauterine devices. The next type is hypomenorrhea, which is light menstrual flow, and in fact, these women may only have spotting. Etiologies include obstruction, where the hymen is not perforated, or cervical stenosis. Some women taking oral contraceptive pills may have a very atrophic endometrium and not have menses. Next is metrorrhagia, which is intermenstrual bleeding, which occurs at irregular intervals and is normal in amount. Common etiologies include endometrial polyps, endometrial or cervical cancer, and exogenous estrogen administration. Menometrorrhagia is defined as irregular bleeding, and irregularity can be in terms of time intervals, duration, or amount of bleeding. Etiologies include endometrial polyps, endometrial or cervical cancer, exogenous estrogen administration, or other malignant tumors. Oligomenorrhea is defined as menstrual cycles which are greater than 35 days apart. Etiologies include pregnancy, which is a very important one. Anytime you have a patient that presents with abnormal uterine bleeding, you must rule out pregnancy. Menopause is another common cause, as well as significant weight loss in the form of anorexia, or tumors which secrete estrogen. Postcoital bleeding is the last type of bleeding that we'll talk about, and this is bleeding after intercourse. Common etiologies include cervical cancer, cervical polyps, or atrophic vaginitis that we see in postmenopausal women. This transabdominal ultrasound shows one of the common causes of abnormal uterine bleeding, that of uterine fibroids. We can see the large heterogeneous fibroid within the wall and cavity of the normal uterus. Two important tips when it comes to abnormal uterine bleeding on the Step 2 exam. Any patient that you have in a case presenting with postcoital bleeding has cervical cancer until proven otherwise. She needs to have a speculum exam and a pap smear done. Also, any patient who is greater than 35 years of age who presents with abnormal uterine bleeding should undergo an endometrial biopsy to rule out endometrial cancer. Here we have an example of a thin prep liquid-based pap smear. On the left, we have normal squamous cells, whereas on the right are HPV-infected cells which are showing signs of mild dysplasia. Anovulatory uterine bleeding is a specific subtype of abnormal uterine bleeding, and before this diagnosis is made, anatomic and neoplastic causes should be ruled out. Anovulatory uterine bleeding comes about from estrogen production with a lack of progesterone. The ovaries produce estrogen, but do not ovulate and thus do not produce a corpus luteum, which would produce the progesterone. This prevents the normal withdrawal bleeding. The continuously high estrogen continues to stimulate growth of the endometrium, and bleeding occurs only once the endometrium has outgrown the uterine blood supply. After what we've talked about with abnormal uterine bleeding, the diagnosis and evaluation should make good sense. I start with a CBC to see if the hemoglobin and hematocrit have dropped, followed by a pregnancy test. The pregnancy test should always be one of the first tests ordered, as pregnancy is one of the most common causes of abnormal uterine bleeding. A PT and PTT can be obtained in order to evaluate for coagulation disorder, and a pelvic ultrasound can visualize any anatomic abnormalities of the ovaries or uterus. An endometrial biopsy should be obtained in any woman over 35 years of age with abnormal uterine bleeding in order to rule out endometrial cancer. Similarly, a pap smear should be obtained to rule out cervical dysplasia. To rule out systemic reasons for anovulations, thyroid studies or prolactin levels can be obtained. Once we have completed our initial diagnostic workup, if it returns negative, we are left with dysfunctional uterine bleeding, which is unexplained abnormal bleeding. Again, we have to rule out all other causes by utilizing the tests we discussed. As a tip on the Step 2 exam, there is no specific test for dysfunctional uterine bleeding. It's a diagnosis of exclusion. Here, I'll review some of the treatment options for dysfunctional uterine bleeding, those for acute hemorrhage, and some of the long-term therapies available. Treatment of dysfunctional uterine bleeding is commonly accomplished via oral contraceptive pills or cyclic progestins. These are great in adolescents and young women who are anovulatory, or in women over 35 years of age who have a normal endometrial biopsy. Treatment of acute hemorrhage involves deciding whether the patient has a hypertrophic or an atrophic endometrial lining. If hypertrophic, we would proceed with a dilation and curettage, whereas if the lining is atrophic, IV estrogen would be the appropriate therapy. Long-term therapies are reserved for patients who have completed childbearing and involve an endometrial ablation where the lining of the uterus is burned, or a complete removal of the uterus altogether. This image reviews the different types of hysterectomy which can be performed. A subtotal hysterectomy removes the body of the uterus, leaving the cervix behind, whereas a total hysterectomy removes both the body of the uterus and the cervix. The radical hysterectomy is reserved for treatment of GYN malignancies. This slide depicts an endometrial ablation. We can see the camera is inside of the uterus, and the device is being used to cauterize the endometrial lining. We're going to move on now to discuss contraception. With each of these, we'll discuss the advantages and disadvantages. Beginning with barrier contraception in the form of female condoms, the advantages is that they offer some protection against HIV and sexually transmitted infections. Additionally, they're under female control. Some disadvantages are that they are not as effective as some of the other methods of birth control available, and they must be left in place for 6 to 8 hours after intercourse in order to be effective. They're also larger and bulkier than male condoms. Slippage and breakage rates are in the order of 3%. Here's an image of a female condom, which has 2 rings and thin material in between. One ring is placed deep in the vagina, and the other ring is left at the introitus. The next form of barrier contraception is the vaginal diaphragm, which is a circular ring with contraceptive jelly on the cervical canal. The diaphragm needs to be placed 6 hours prior to intercourse and left in place for 6 hours afterwards. A somewhat similar form of barrier contraception is the cervical cap, which is placed over top of the cervix through the vagina. The advantages of these forms of barrier contraception are that they are under female control. However, they do not protect against sexually transmitted infections. Some of the disadvantages include the need to be fitted properly, requiring advanced preparation, and the fact that improper placement or dislodging reduces their efficacy. Next, we'll discuss some of the most popular forms of birth control, that of combined oral contraceptives. There are two main oral contraceptive pills. Those that have a combination of ethinyl estradiol and some form of 19-nortestosterone or a spironolactone derivative such as drospirenone as the progestin product. There are also those that have progestin-only agents. The typical use is 21 days of active pill, followed by 7 days of placebo, with menses occurring during the 7 days of placebo pills. The physiologic connection here is that progestins suppress LH and thus ovulation. They also provide thickening of the cervical mucus, whereas estrogen suppresses FSH and prevents maturation of the follicles. It should be noted that there are many different formulations, monophasic, polyphasic, cyclic, or continuous, that can be used effectively. There are several different advantages and disadvantages with use of oral contraceptive pills. First, they're very effective if used perfectly. In addition, they do have reduction in rates of ovarian carcinoma and endometrial carcinoma. Finally, they're very easily reversible with return to normal menses and baseline fertility. The disadvantages is that they're very user-dependent and they're not as effective if they're not used perfectly. There's also a risk of thromboembolic disease, and there are several contraindications, including active thromboembolic disease, undiagnosed vaginal bleeding, suspected or known pregnancy, coronary occlusion, smokers greater than age 35, impaired liver function or neoplasm, and migraines with aura due to the increased risk of stroke. We'll review some of the other forms of contraception which have the same physiologic principle as the combined oral contraceptive pill. The first is the vaginal ring, which is a flexible ring inserted in the vagina. It releases both estrogen and progesterone on a constant basis and remains in place for 3 weeks. When the ring is removed, a withdrawal bleed will occur. The vaginal ring has similar side effects and efficacy to oral contraceptive pills. The transdermal patch includes both estrogen and progesterone and is placed on the skin for 7 days. Each week, the previous patch is removed and a new patch is placed. There is some caution in women who are over roughly 200 pounds given the concern for decreased efficacy. You have 3 weeks with patches followed by a patch-free week during which the withdrawal bleed will occur. Patches should not be placed on the breasts, and the side effects and efficacy, again, are equal to combined oral contraceptive pills. Here's an example of the transdermal patch, which can be effectively used for contraception. Another form of hormonal contraception is depomedroxyprogesterone acetate. This is an intramuscular injection which is given every 3 months. Some of the largest side effects is irregular bleeding. There's also some concern about bone mineral density with very prolonged use. However, there's no difference in fracture rate, and bone mineral density returns to normal after discontinuation. We're now moving in to the long-acting reversible forms of contraception. The first is the implantable contraceptive system, which releases a progestin on a continuous basis. It inhibits ovulation and thickens the cervical mucus. The implant-on device in the United States is a 3-centimeter rod placed in the upper extremity and is good for 3 years. There are 2 types of intrauterine devices currently on the market in the United States. The first is the copper T device, which provides excellent contraception for up to 10 years. The next is the levonorgestrel device, or the Mirena IUD, which is effective for 5 years. Worldwide, IUDs are the most commonly formed of birth control, and they're also the most effective, aside from sterilization. 2 clinical pearls for the Step 2 exam. Mirena IUDs and copper IUDs do not increase the overall rates of ectopics, since the overall rates of pregnancy are much lower. However, if you're pregnant with an IUD in place, your risk for an ectopic is much higher than your matched controls. Additionally, these devices can be associated with pelvic inflammatory disease, and patients need to be selected carefully. Here is an example of proper fit of the levonorgestrel IUD in a model uterus. On this flat plate of the abdomen, we see the copper T device as it lies inside of the uterus. Finally, we have the forms of sterilization, which are designed to be permanent and irreversible. The 2 types are tubal ligation or occlusion, or a vasectomy, which is ligation of the vas deferens.